So once again, good morning for those of us in the US and those regions. For those in Asia, I guess it's almost, you're supposed to say good night. It's evening here in Nairobi, and to colleagues and friends, thank you so much for joining. My name is Samuel Munyuin. I work for African Institute for Children's Studies. I'm the executive director, and I also lead the research component. We are very privileged in this call to join friends from Clinton School. At the appropriate time, I will have Haley introduce herself and indeed what they do at the Clinton School, but I'll come to that. So before I hand over to her, allow me to just make a few introductory remarks. So as I welcome you, as I've mentioned, this is a collaborative effort. African Institute for Children's Studies is a knowledge management organization. We are a Pan-African non-profit organization seeking to improve the quality of services. And we do that by bringing together experts on children on different matters, whether it's health, protection, education. And through that, this concoction of people, so to say, try and link academia and practice, because that's often a big gap. And through the knowledge that we generate from research, we use it to inform policy, capacity building, and this kind of interventions that we do. As one of those examples, we've been privileged this year to have an intern, and we hope this can continue with the Clinton School of Public Service. And we've had such collaborations also with other universities. I'll give you an example of Arizona State University, the Daystar University here in Kenya, and the Makerere University. And we really look forward to more. This particular presentation is looking at improving access to public financing for mental health services. This has been inspired through this partnership that we do have with Kenya Association for Intellectually Handicapped, who are based here in Nairobi. This is an organization that has strength in doing community-based rehabilitation for mental health services. And we also have a partnership with Camille Organization, who have great experience in providing community-based mental health clinical services, really cost-effective measures, very sustainable approaches. And this has been funded by the Open Society Foundation. We are grateful. I know part of their support comes from people from the US, and I think even this kind of collaboration, the Clinton School of Public Service and other American organizations will be great. And also the Open Society Initiative for East Africa. So really grateful. Let me point out just two things that have been in the media recently. Last month of July in Kenya, I think, I don't know whether it's just because the reporter had more interest, but there are two different reporters. But as you can see there, there's an alarm that was brought out by the Director for Criminal Investigation, who indicated that for the first time we hit a figure we've never hit as a country in just 3 months of suicide rates. And this, I'm sure, is not unique to Kenya. It's a global issue. And this, I think, really brings into context why it's then important to address this matter. Just 3 days later, we had the Cabinet Secretary in charge of internal security, is in charge of police and others, being summoned by the Senate to indicate what action is being done to protect or to prevent increasing suicide rates among police officers. So suicide really, and suicide ideation is one of the forms of manifestations of mental health issues. And we are not also ignoring that there are other mental health concerns such as mental disability. And these are very critical. So what we really want to get into a conversation, I don't think we'll be able to answer all the questions here, but we hope that we will, through this conversation, have a critical mass of us that will be interested and will be ready to try and make sure that we make the countries, the policymakers, to be aware, to be able to prioritize. I usually say where the rubber meets the road when it comes to public policy is financing. So I think this is very quick conversation that I hope we could all be able to have. So I'm very grateful to Haley, and I'm going to invite you now to take it up from here. Let me stop sharing my screen. Once we are done with her presentation, we'll open it up to contributions from some of you. I know it's just about 1 hour, but we'll get the most that we can. We'll eventually have a policy brief that will be more detailed than this presentation. And hopefully we can have more partnerships on this one. Over to you.
Thank you, Samuel. Let me share my screen. Can everyone see that?
Not yet.
Okay, let's try this again. Okay, now, okay.
You can see it.
Great. All right. So I've been practicing a little bit of Swahili with Samuel. He's been helping me. So habari kila mtu means hello everyone. Shukran sana kwa kujiunga nasi leo. Thank you all so much for joining us today. I'm very excited to be discussing the economic value of public financing for mental health care in Kenya. Oh boy, you can't see that picture, can you?
We're seeing the presenter window.
Oh, I'm so sorry. Hang on, let me back up out of this. Okay, let's try this again. How's that?
Yeah.
Okay. Okay, so I was going to tell you all a little bit about me. As Samuel said, my name's Haley. My name's Haley Gilliam, and I'm a student at the University of Arkansas Clinton School of Public Service. I did my undergraduate degree in psychology, and I've always been interested in mental health and been increasingly an advocate for mental well-being. Excuse me, as part of our Clinton School curriculum, we do an international public service project, and I chose to work with the African Institute for Children's Studies because they were working on a mental health care program, community-based, and this was a facet that I wanted to join in on. And so I'm really excited to have been working with them this summer to advocate for mental health care. So for the introduction, we'll be talking about 3 main points. So first, what is the place of mental health in today's global society, in global context? Number 2, how are countries such as Kenya responding to these mental health needs? 3, is there an economic benefit of increasing investment in mental health care? And so before I move on, I'm going to define these few key terms that you've heard and you might hear throughout the presentation. So the CDC, or the Centers for Disease Control and Prevention, defines mental health as our emotional, psychological, and social well-being. And in contrast, the CDC describes mental health conditions or mental illnesses as conditions that affect a person's thinking, feeling, mood, or behavior, such as depression, anxiety, bipolar disorder, or schizophrenia. These may be occasional or long-lasting and affect someone's ability to relate to others and function each day. Next, the American Psychiatric Organization states that mental or intellectual disabilities involve problems with intellectual functioning, such as learning, problem solving, judgment, and adaptive functioning, which are activities of daily life, such as communication and independent living. And lastly, adequate public financing refers to the global recommendations for the proportion of government and health budgets that should be allocated towards mental health care. So next, I'll move on to my methods. So to do this study, I largely stood on the shoulders of giants. I dug through tons of Kenya Treasury and Ministry of Health documents looking for different health and mental health numbers. And I also looked at tons of related literature. And among this literature, I found data at the Institution for Health Metrics and Evaluation. They have a global health data exchange database where I found a bunch of data on different non-communicable diseases, and I decided to compare some of those. So moving on to the global context. So our, excuse me. So across the globe, the mental, neurological, and substance use disorders affect over 25% of all people at some point in their lifetime. And this number is similar for those in Kenya. Although there's limited information available at times on the prevalence of the burden of mental illness in Kenya, it's estimated that 10% of the population is affected by mental illness. And this increases to 25% of outpatients who receive routine care at different clinics. And using the 10% of the population number, looking at the 2019 Kenya census, this means that there are over 4.75 million Kenyans suffering from mental illness. So the most common of these illnesses are depression, substance use disorder, bipolar mood disorder, schizophrenia, and anxiety. And next, this is part of what I did through the Global Health Data Exchange. So you'll see that I took a bunch of different non-communicable diseases, and I basically took the top 6 when you look at the disability adjusted life years and their prevalence. And so you can see that mental illnesses comes in at number 3, even above cancers, which is very high. And this, excuse me, the non-communicable disease strategic plan was looking to scale up some treatment for each of these, and mental illnesses came in at 2%. They were only going to fund mental illnesses at 2% of the non-communicable disease budget, from what I understood. So that was interesting. And now the next part, I disaggregated or separated the different highest, like most common disorders from mental illnesses. And so you can see the highest prevalence and disability adjusted life years came in with the depressive disorders, and then next was anxiety disorders. And these tend to have the highest impact on disability adjusted life years and impact on people's ability to work and be productive in society. So further, what's at stake? The socioeconomic costs of mental illnesses are very, very huge. So one study looked at across 36 large countries and projected that no more then 12 billion days of lost productivity are due to depression and anxiety disorders. And this cost an estimated 925 billion US dollars. And so this is just looking at mostly the productivity that people lose when they have to suffer in their daily lives from these illnesses. So with the context of COVID-19, one recent study mentioned that it's a traumatic experience. We know this from past, I'm sure they've looked at past epidemics, pandemics, these large sweeping experiences are traumatic, and they introduce large amounts of stress. And these cause symptoms of depression, anxiety, and insomnia to appear or worsen. And additionally, there's been no formal mental health response plan, nor surveillance system in place in Kenya to help kind of gauge the mental health aspect of what's happening with COVID-19. So that's putting a lot of these mental illnesses that have been caused by or worsened by COVID-19 to be swept under the rug, especially knowing that Kenya's and everyone is scaling up their resources to fight COVID. So that's part of that. Next, this is what's the response? What is Kenya doing to address the mental health burden in their country? So it's estimated that Kenya spends only 5.5% of its total health budget on mental health. And this is actually 4.5% less than the minimum that the WHO recommends that countries spend. And I believe South Africa is one of the only African countries to hit this minimum target. But yes, oops, I'm sorry. Let's go back. Okay, so what I have here is data that I got from the Ministry of Health from Kenya. So you see the blue bars indicate the percent of the total government budget allocated to the health sector at large. And so it held steady at about 7.5%, and it rose. And there's not an actual health or mental health budget in Kenya, which is why this is the estimate of over these years. Even when I was looking for mental health spending data in the budget papers, it was very scant, and most of it was being spent on ministerial expenditures like salaries and like cleaning supply. There was things that weren't having to do with mental health services. So anyway, so you see this very large difference between the persons allocated, and they did not scale up as far as we know, they did not scale up the mental health spending even when the health budget rose. So this is what I was looking at for the commodity cost estimates for the non-communicable disease strategy, where I was comparing these different non-communicable diseases with mental health. And for some reason, it circled the wrong number. So you see this 0.2. I don't know if you can see my mouse, but mental health, they were allocating 0.2% for between the years of 2021 and 2025. Even though mental health in the earlier graph, which I can show y'all again at the end if you want, it's above 11% in both disability adjusted life years and prevalence, yet it's being the non-communicable disease sector wants to only allocate 0.2% of its budget in these next 5 years to mental illnesses. All right. So what is the impact of this inadequate funding for mental health care? So, excuse me, according to one article, Kenya's health ministry estimates that 75% of people in need of medical services for mental health challenges cannot get it. And this is could be due to underfunding for staff, which you can see in this next point. Fewer than 500 specialist mental health workers serve Kenya's population of over 50 million, which I think that amounts to some decimal point. It's not one specialist per maybe 1 million people. I could have that wrong, but very small number. And one of the worst outcomes of this low mental health funding, almost non-existent funding, is the state of Mathare National Teaching and Referral Hospital. This hospital has been the hub for psychiatric services in Kenya. It's based in Nairobi. It's been the hub for, I think it's about 100 years. I could be wrong on that. But there are reports that are saying it hasn't been updated. It hasn't had sweeping remodels in these 100 years that it's been standing or so. And so the mental health task force, which I'll get into that later, but they have an article about this. And so it talks about the dilapidated, unsafe conditions, talking about how there's no toilets. I saw pictures of just holes in the ground where people are expected to go to the bathroom. And if and it wouldn't be safe, or wouldn't be deemed safe for I just normal, I guess, people in the larger world. And the condition of this hospital brings further stigma to those who are already stigmatized. I read in one of these reports that people who leave, if they ever say they're from Mathare, no one wants to deal with them, even if they've been rehabilitated, ready to go back out in the world. It just brings a really bad name. So, and this quote pretty much says it all. It says, "No citizen of our country should live in those dehumanizing conditions." Moving on. Okay, so to our last point, this is what we want to know is there an economic benefit to increasing mental health care funding? So according to the WHO actually says this, and it came from the Mental Health Task Force article. For every shilling invested in mental health, the return is 5 shillings. And so that alone, the statement is very sweeping, and like I just think it's very strong, a very strong case. And there are a couple more articles that back this up. So a study in Denmark in 2021 found that for every point increase in mental well-being, and this was measured in 2016, there was an association with lower healthcare costs and lower cost and sickness benefit transfers per person in 2017. And then further, there was a study in 2013 that looked at different income level countries. So it included low income and low to middle income countries. And Kenya is considered low to middle income by World Bank data standards. So it looked at how the scaling up of treatment for depression and anxiety disorders found that scaled up treatment leads to 43 million extra years of healthy life globally. And these lives have an economic value total of $310 billion and lead to large economic gains. There were a bunch of numbers in that and in the article, and I would be glad to share them. There was some ratios, I just didn't take them out, but it was very, very promising. That's what that is. And then here we are at the conclusion. So so with this study, I found strong evidence in support of increasing public mental health care funding. We have benchmarks set by the WHO, which is 5% minimum mental health allocation. If Kenya is currently at 0.5% without having an official mental health care allocation, budget allocation, it needs to first get a healthcare budget, have it set, have it in writing, anything, to make sure there's an actual division for mental health for the budget, and scale up over time to 5%, ideally. And I wanted to mention there's opportunity for positive change, and with everything that I've read, the documents that I've read with past policy briefs talking about stigma and touching on financing, I really think change is on the way for mental health care, and this is also the fact that you all are here and we're talking about this, I think is a great news. So the mental health task force, which I mentioned before, the task force was begun in 2019. The president, I believe it's Uhuru Kenyatta, he designated the mental health task force to determine like different barriers to mental health care, and just be an advocate overall. So they're getting off the ground. And then also the Kenya Mental Health Action Plan for 2021 to 2025 is looking to scale up. I kind of forgot what all they're doing, but they're looking to also help out too. It looks like there's definitely more scaling up of awareness of mental health care. And now I have this last sentence here. Throughout most of the Ministry of Health papers that I read through, the vision for the Ministry of Health is to support a healthy, productive, and globally competitive nation. And so this is what I've gathered from this. Increasing public financing of mental health care will support this healthy, productive, and globally competitive nation in Kenya. And with that, I think I'm done, and you can ask any questions you want.
Thank you, Ale. That's really great presentation. I'm sure each one of us has a bubble moment, hopefully. I think for me, some things that stood out is the figures on just how big is the burden of mental health. And I think this could actually be lower because there were findings from studies that were pre-corona, pre-COVID, but still at 10% of general population in hospitalization, outpatient, 25%. I think the National Strategic Plan on NCDs actually indicated 40% for inpatient. And I think it makes sense because if you're admitted for a cancer treatment, then there are mental health issues in there that many times are completely ignored. So we are talking about a matter that affects the entire well-being of people and even the ability to recover from many other illnesses or conditions that they may be going through. Plus, let's not forget that there are persons who are living with mental disability, and that requires a long-term management, but more so importantly, from a human rights-based approach, very critical that we must remember. It's not about the traditional way of, let's fix it. I think one of the gaps we have globally is a lot of this is approached from a clinical model, where we are looking at, can we give medication and this stops? But how do we address chronic conditions? That's a major one. I think the other one that stood out for me is just the fact that we do have there is also the fact that the budget, 0.2% of the Ministry of Health budget. If I got you right, Haley, that we should be aiming at 5%. I think we have some task here. It's not easy. Well, when you look at our budgets as a country in Kenya, that is better. At least we are seeing some about 360 million Kenyan shillings. That's what, about $3.6 million being allocated. But again, most of that goes into human resource rather than actual. Thanks for pointing out some opportunities. I'm aware that at least right now in this government planning, in the next about 2 years or 5 years, we should have 2 other Mathare size kind of mental health facilities that are coming up. But it looks like our work is cut out. Before I say much and before I allow others to come in, I want to invite, will it be Nicola or who? Some professors who worked with LA. Kindly, some words before we open it up.
Yes, thank you so much. Thank you, Haley. And thank you, Samuel. I've heard some wonderful things about your partnership and your leadership from Haley. So we're very thankful for that, this collaboration. I do have a question, and it can be for Haley or it can be for really anyone on the call. Seeing some of these statistics have been very helpful to paint the picture of mental health in Kenya. And I'm curious what role stigma plays in the numbers that we're seeing, because in the US, we're seeing trends of decreasing stigma, in fact, and surveys are showing that it's becoming more okay to talk about mental illness, to report mental illness. And so I believe that has a relationship with the prevalence that we see. So I'm just curious about the situation in Kenya in terms of stigma and whether there's actually underreporting going on here and these numbers may be greater.
That's a good question. I was just going to touch on the fact that I kept seeing stigma come up so often in those documents that Samuel shared with me with the situational gap analysis. We were looking at primarily people in the justice system with mental disabilities, and how they don't have good representation. Like people, their lawyers they can't explain things like adequately for them, and they just don't care to. The people with mental disabilities have no idea what their sentence is, and they get left in the system for a very long time. And I guess in that, the stigma is it just felt so, just reading those kind of stories, it was more just they had no idea what the mental disabilities were, didn't understand, and didn't care about the people with those disabilities. So that's what I was thinking of. But did you want to say something, Samuel? You'd probably speak to it better.
You're right that I think even coming from a lot of contexts in this region there's not been much conversation around mental health. I think if you looked for equivalent words in our mother tongues, a lot of them will not be very kind. And I think that's where it begins from. Plus the fact that many times we will respond to what is physical, what I can view. So when it's not physical and people can see it, then it's not prioritized. A good example is we were recently doing an analysis on non-communicable diseases policies, and we see that between the period 2012 and 2017, we had a sharp rise in number of policies that are addressing especially cancer. And someone said in the key informants, it seems like it's because a number of our leaders in the public, members of parliament, really, we lost a number of them during that period. And so we had a sharp rise. So I think there's the element of it not being something that the way you be described is not very good. So self-stigma is in it. And like Haley says, even within the facilities then, it's not looked at as a priority matter. But just like in the case of the US, I think COVID has made it perhaps much more acceptable to talk about this. There's been more conversation. So the more we have conversation, the better it is. As AICS, we've been working with some teams here and thinking about making a technology that allows you to do self-assessment. And within yourself, you can know, I'm in the green, I'm in the amber, or I'm in the red band, and where do I go for services? So that within the community. So a community-based approach is very critical to this. Good question. And I see quite a number of questions in the chat box, but anyone else from the Clinton School of? Okay, great. So I'll quickly, I'll do that towards the end. We have some good 20 minutes. So let me open it up. You can raise your hand up and we'll allow you to speak. Anyone in the audience, ask a question, bring in a new perspective.
Sam, I have my hand up. I don't know if you can see me.
Okay, I see Kukubo Barasa. Prof, go ahead and speak.
I have a brief one. About stigma. I've experienced service for quite a few years, ranging from the colonial time up to now. Now, when I was a child, up to adulthood, when I went to college, there was only one mental health hospital. That was Mathare. And up to that time, it wasn't a hospital, it wasn't a care area, it was a rehabilitation or a prison, a place where recalcitrant characters were thrown, to get out of society. The rest of the care, which was better care, was in the communities, in the homes, in the families, and therefore the level of stigma ranged quite widely. If you had been to Mathare, then you are considered, as the government suggested, you are a bad person, you are a nasty person. But if you are mentally ill or you had some mild mental illness and you're in the family, you're just normal. There was nothing unusual because mental health was not unusual. There was much less stigma relating to people who are taken care of at the family level than those who are taken to the hospitals. I remember when other hospitals took up this matter, like Kakamega Hospital in the 1970s. It was very difficult to get families to allow their members to go for care in that hospital because they said, we don't want to have this other Mathare here. So the stigma element, if you look at it historically, you'll see there has been some shift, which is very fascinating. And if you dig a little more deeply, you'll see attitudes towards people with mental health issues differ very widely from the most compassionate, most supportive, to ignorance, and perhaps related to what people were taught by the government of that time. Thank you.
Good point. And I think what we really need is to document these very traditional ways in which we supported persons with mental health needs. I think that is really the missing piece. And like you rightfully put it, if we can do it in a very safe space, then we'll encourage people to be able to speak about it. Yes. And let me acknowledge that Dr. Kubo Barasa was the first chair of our board and a founder member of AICS. Thank you, Prof, for making time to be in the call. Reverend Taylor Nyanhete, all the way from Zimbabwe. Kindly speak, bro, and thank you for representing AICS Zimbabwe there too.
Thank you, Sam. Good afternoon, everyone. It's 13 past 4 in Zimbabwe. It's a very interesting discussion that is going on. Thank you for the presentation, Haley. Am I right? The issue of mental health remains stigmatized in the African context. The reason why, Sam, you're talking about the words that associate with mental health, they remain negative because it's associated with witchcraft. It's associated with, in terms of our belief system, even in the Christian communities, it's related with the demons. So not a lot of governments have really paid attention to it. And even if you look at the experts that are in this particular field, they are still limited in terms of their numbers. But what we have seen now in COVID, there have been many issues of mental health. I think because of the magnitude of the pandemic itself and how it continues to affect many communities across the globe. So it has made people lose jobs. It has made people remain in restricted spaces where they cannot interact. And we have seen an increase in violence because of the limitations of COVID. Yeah. So this is why we're beginning to see a lot of people talking about mental health. I've even in Zimbabwe, I've seen a lot of psychologists coming on board talking about mental health. It appears it's now receiving attention. But in terms of funding from the state, it's still very limited. If you go to institutions that treat people with mental challenges, the infrastructure is very poor, and it's always put in a corner or isolated from the main wings of the hospital. I don't know why, but this is my observation that I've seen as I've gone around the hospitals in Zimbabwe. So there is still a challenge in terms of our acceptance of mental health, that even if a person looks normal, they may have some kind of mild mental challenge, but no one has really gone into that to say which challenge in mental health would you say is mild, severe, or normal. So I think there's still a lot of work to be done around mental health, in my view. And I thought I would just come in and give my perspective.
Thank you.
Yeah, thank you.
Thank you, Reverend Taylor, for that emphasis. The linkage between community facility, very critical. The assessment tools. I remember I worked with someone called Lisa doing work in Zimbabwe. Can we have contextualized or assessment tools that are culturally sensitive and allow us to then be able to even have a much more better way of making referrals? Thank you. Alex, I see your hand is up. Alex Maina.
Yes, thank you. Thank you very much. My name is Alex Maina, representing Health CSOs Network in Kenya. Let me first thank the presenters, facilitators for the good information that they've been able to give us. And I really agree that yes, there is need for more funding towards mental health. We have in the recent past experienced many cases of mental problems, many people killing themselves and actually killing other people. And of course, the statistics that were released by the Kenyan government about the number of deaths that have occurred recently because of mental health is really alarming, which then means that from the CSO's perspective, we have a lot to do in terms of advocating for more funding into this sector. But now the question is, as we sit to think about advocating for more funding into to this subsector, what exactly would we really be advocating for money to do? Of course, we've talked about the mental hospital, and I'm aware that the government is planning to shift the current Mathare hospital to Karen or something. That's what I heard some few days ago. But is that really going to help the whole country? Mathare hospital is in Nairobi. What about those in Mombasa, Garissa, and other places? So as much as funding is going to be given towards a construction of a modern hospital, mental hospital, we need to be guided on what are the other ways of ensuring that mental illness is dealt with. What will the budget go into doing into these other places? We need your guidance. Thank you very much.
Thank you, Alex. Hele, do you want to respond to this on the scope of our good mental health services? I think you had a slide on that. That will help us have the conversation, but I agree with Alex. We've got to think beyond the facility.
Yes, thank you for that question. I was thinking about some articles that I read. I just didn't include them on this, but some of them had examples of community-based treatment for mental health that were low cost. And I think one of them might have been in Kenya or a similar African country. But I do have a list. I do have a really extensive list of articles that I came across. And I'd be happy to share some of them with you. Yeah, I don't remember the details of it, but I do know it touched on the fact that there's not enough government allocation. So you kind of have to, like, the community started to take care of things themselves, coming up with different treatments that would not require the cost from the government. Yeah. Does that help?
Yeah, good points. And I see Angie is also reminding us we can borrow from the WHO pyramid framework. Angie, you also are aware that there's been a bit of criticism on WHO's model, too much focus on medical model, but I agree that's a good starting point. We, as an institution, we responded to the last budget, 2020-2021, and gave a memorandum to Parliament. Then what was allocated for training of health workers, but it wasn't very clear what cadre of health workers do we need to train. Who has the ability to go into households? Because in countries where health facilities are not, say, within a radius or a distance of about 1.5 miles or 2 kilometers from each person, they rely a lot on a community-based health system. And in our case, community health workers play a very critical role. The nurses, in most of our health facilities, they'll be the nurses. So do the nurses have the capacity to diagnose? Like Hele pointed out, we only have 500 trained people who are in this. Again, it's a 50 million population. So I think it begins by, one, investing more in community health systems and community health workers, doing awareness. I think if people can do their own self-assessment, this will be very, very critical, so that then we can come in on that further. So again, let's also document good practices. What has worked? Where is an evidence-based model that focuses on community? I see we have about 8 minutes. A lot of hands are up. I want to invite Sarah to Meriwe. Okay, you will help me pronounce the other name. I think from Uganda. Kindly go ahead. So I'll give Sarah and then give maybe Matthew and Paul, and that's it. And let's keep them brief. Then I'll invite my partners in this project from Kai and Camille, a few words, and we'll wrap it up. Sarah, over to you.
Thank you very much, Samuel. And it's pronounced as Tushemedire. It means we are happy. Thank you for the presentation. My question is, okay, we see that there are very many uprising organizations that are rendering services in mental health. How do we get the funding to the actual organization from the government itself? But also, what strategies can we use to increase awareness among the government officials? Because we have talked and the data shows it, but to see that they're not increasing the budget. Last question, how can we mobilize funding? Because even if we have all these dreams and all these ways we want to support and increase mental health services, but what are the practical ways we can use to mobilize funding? Thank you.
Good point. Maybe to save time, Haley, you can respond to the first one if you don't mind. Let me respond to the second one. Just some thoughts. I think COVID has shown us that it's about priority. Is this the conversation on the table? And so we need, as many of us, bringing in evidence. Here's the data. This is a problem. Because we've seen money being moved for COVID that was not there. If you spoke about this money a few months ago, we'll have said we don't have money. So is it priority? I think let's bring the evidence, put it before the legislators and before budget makers. Ellie, do you want to say something about the other question?
So the other question was how to make it, how to practically put this in the forefront, right? It wasn't to do with the government officials, how to mobilize. Okay, I'm not sure.
How to get the funding to the organizations that are pioneering the mental health need and support and care that individuals need.
Right. Okay. I don't have an answer right now. I would like to find that out though. How to make sure that's funneled in the right directions, because we did see, looking through the budgets, that there was a, what's it called, deficit. There was budget for, I think it was the mental health council. No, I don't remember the name.
The mental health board.
Yes, there was some expenditure allocation for that, but it was again to do with the salaries and administration type things. But there was a deficit that happened, and we don't know where that funding went. So that's another aspect that I think that would be great to look into, make sure it's being used in the right ways.
And Sarah, I think I hear you also speak about user-led advocacy. Let the people who wear the shoe really be the ones to speak, and let's make sure that in our advocacy they are present and they're the ones who actually get the resources. If I'll give my colleague a minute or so from Kai, they have very good programs where as an association of persons with intellectual disability, they are able to support each other in doing this. And for sure, they're able to give us more effective, more efficient models for service delivery than anyone else. Matthew?
Thank you so much. Good evening, all. and good morning wherever you are, or good afternoon. My name is Matthew Mtiso, and I represent an organization called the Coalition Action for Preventive Mental Health. Currently, we are about 120 CSOs in mental health in the country with different initiatives. I'd like just to highlight some few things that I think are pertinent even to this conversation as we speak about investments, increasing investments, especially when we talk about CSOs. It's very important that CSOs also have a common voice when they're speaking about funding. And CSOs, we can all agree that they happen, one way or another, they happen to be the first responders at the community level when it comes to initiatives that touches on communities and programs that actually impact people. So there's a need for collaboration and coordination among CSOs, perhaps even from at HealthNet level or maybe at national level. Secondly, I'd like to also talk about the issue of funding. We're talking about funding in the context of the government, mostly when we have these conversations. What about other international traditional organizations like the Global Fund, for example? What is the association? How can we interlink or integrate mental health into these global initiatives like malaria, TB, HIV, the Global Facility for Maternal and Child Care? How is funding also be able to be channeled to these initiatives, but at the same time with a component of mental health? Because we all know that mental health has an aspect that touches on every other sector of the society, or every other disease, one or another, or health issues has a relationship with mental health. So that's also, I think, a need that we need to advocate for at that level, to see how mental health can also access some of these international funds. And lastly, I feel again that we are honored to be here, and we will be keen to see more of these conversations, even see more collaborations and partnership that we can build among various stakeholders that are here today. Thank you so much, and we are glad to be here. Have a good evening.
Thanks. Paul, less than a minute, and then Martin, when you speak, you could wrap up also as one of our partners, and maybe Fatma.
Thanks, Ali, for the presentation, and thanks, Sam, for the coordination. Mine is on some of the pertinent issues, and looking at the desk reviews for what has led to global action based on funding is a very concrete body of evidence which supports the claims. Yes, we may have numbers being reported, we may have assertions being meant, but the fact of the matter is, as long as there isn't concrete evidence, like they used to have HIV, which was being reported, people were dying, the numbers were being reported. But when a survey was done and the evidence was so overwhelming, it was easy to be able to get that funding come by. So I think as we speak, there is need to look at how can we possibly try to see from the meager resources which may be available, how can we be able to have a population level survey? Yes, population levels, everybody cannot be interviewed, but a representative sample within the counties in Kenya, and that will be able to give a very good evidence on exactly where we are in terms of mental health within our communities, and see where we are averagely as a country and by county, and that will be able to see, to provide a background on which we can be able to say, yes, here we have a problem and there is need for action, and this is the evidence which we have. So I think that will be a good point to be able to start from. Thank you, and over.
Great emphasis, evidence. And by the way, I've engaged more and more in advocacy for public financing with Treasury in Kenya. They're looking for data. If you don't have data on also what is the impact on what we've invested so far, they won't put more money. So we've got to really do this together. And I think we need a joint initiative to put this together. Over to you, Martin Wadhika.
Thank you very much. And very interactive session. So when it comes to mental health financing, is there a possibility that we can be able to fund more community-based services? More community-based services will actually mean increased accessibility to mental health services in the communities. Actually, what we're actually doing wrong is we are being able to focus more on the institutionalization. For example, when you look at our budget as Haley, I hope I pronounced it right, when she was actually giving that 0.5% of the budget actually just goes to mental health. And when you closely look at this, the 0.5% actually just goes to Mathare National Teaching and Referral Hospital. No other county hospitals are actually getting this money. Does that mean that there are no, mental illness is not in other counties and it's only in Nairobi? Because 0.5 is only in Mathare National Teaching and Referral Hospital. So that means that the counties in Kenya are left with no resources to be able to take care of persons with mental health issues. So, on my opinion, let us focus more on service provision in the community level. When we focus more on the service provision in the community level, what we will be doing, it's going to create a sort of ripple effect. And this will mean that more people will be getting services in the communities and less people will be going to institutions. That will actually not only improve accessibility, but it will also increase the quality of service. Because when we are talking about institutions having, everyone from the country actually just going towards an institution like Mathare, and with hospitals in Kenya, because when you look at data as well, we have more than 5,000 hospitals in Kenya. And of the 5,000 hospitals, only 27 offer mental health services, which is actually sort of quite 0.7% of that actually is just being able to be channeled toward mental health. So my opinion is, even for people who are interested in the funding of mental health, let us focus more on community-based services rather than institutionalization.
Great.
Thank you very much.
Thank you. Thank you all for your patience too. I know we've gone beyond the 5 minutes. I'll just wrap it up with this. One, I hear us say we need more conversation. And I think this conversation needs to go to the spaces where we influence the decision makers on who is putting the money where. We need evidence. So like Paul mentioned, can we have population-based surveys? This require collaborative projects. A lot of governments will not put money into that. But I think we can demand that they put a certain portion, and we have partners coming on board. I hear a lot of, can we look at what has worked for us traditionally? I liked what Kukubo Barasa mentioned very earlier on, that even him growing up many years back, there were community systems that worked. I think that will address stigma, and that will empower, will build more sustainable measures towards this. Like Martin has emphasized, community-based. Do we have models that are working? And be able to present those models in the budgeting that is happening at the county and the district level for countries that use districts. In Kenya, we have decentralized health services. We cannot therefore ignore the investment that counties are doing on the mental health. And let's destigmatize. Let us make this a common, usual conversation. I want to once again say thank you, Helen, for this great work, and your college. We look forward to more engagement in public policy conversations, and really be very strategic on being able to make an impact on this work. Otherwise, thank you very much. Let's catch up soon in the next work. Have a great day or evening.
Thank you.
Yeah.
Okay, thank you, everyone.
Very much. Thank you. Bye.
Thank you. Bye-bye.
Thank you. Bye.
Thank you. Bye.